for the introduction and thanks for the opportunity to talk about a project that I hope, or we think, is maybe starting to be one of these innovative ways that we can rethink palliative care in this space. Next slide, please. Could I have the next slide, please? Thank you. So most people will know, but palliative care is a particular focus of care for people with serious illness, and the focus is on providing relief from symptoms and from the stress of the illness, and it also includes the family. And so what's different, or what's particular about palliative care? It's not about being in a particular place or having a particular illness or illness stage. It's in conjunction with usual care, complements usual care, explicitly focuses on not just the illness, but the whole person, explicitly includes the family. And I guess the goal is quality of life. So that's whatever the person nominates it to be. So we don't tend to measure blood tests or CT scans. We're really very much focused on what that issue is for this person at the time. And palliative care works. We know from a series of international studies, and even though there is some variation in how they're reported, that there are benefits for patients in terms of improved symptom management, improved quality of life, feeling supported and able to access information and decisions. Similarly, families feel that they have access to more information and support and preparedness. And for communities, I guess more broadly, improved bereavement outcomes and also improved use of health services, such that for those people who wish to be cared for at home, there's a greater likelihood of that being able to be achieved. Next slide, please. And yet, even though there are these benefits, there's a number of people are not accessing this, and those who are, frequently it's very late in the illness, so that they don't seem to be able to access the full benefits. And some of the reasons for this is the uncertainty about when people should be referred, this notion of not being ready yet, that palliative care is at when all the other treatments are finished, as opposed to concurrent with usual care. And the issue that Charles brought up around hope, that there are perceptions and misperceptions about palliative care held in the community and indeed by some health professionals. And so that means that the conversation is hard and avoided, and sometimes it's easier just not to go there. Next slide, please. And so we really needed to do something different and to really explicitly address some of these barriers. And we were fortunate to get some funding for what's called the Care Plus study, which is an implementation study across a few hospitals of early palliative care into routine practice for people with cancer. Next slide, please. So what we did was we approached the clinical teams and said, for a series of cancers, what do you think? And if you were to have palliative care involved, which we're calling Care Plus in this instance, what time point would be the best time for this illness that you are experts in? And so we asked them to nominate what might be trigger points, so that everyone who reached that point in their illness, palliative care just happened by default. It happened through what we call the Care Plus system, and the notion was that we were positioning this as just part of high quality care. This is what we do. It's not something special, or it's not because you're doing particularly badly. This is what is good care at this time. And one of these cancers was nominated as pancreatic cancer, and the trigger point were those who had unresectable or metastatic disease. Care Plus consisted of 3 outpatient appointments. Outpatients because it was part of the usual culture of care. People were coming in for their other treatments, and they saw the Care Plus - the palliative care person at the same time. Once a month for at least 3 months, happened alongside usual care. And at the end of those 3 months, there was a GP case conference just determining who was responsible for what. And for those who, the ongoing care plan was worked out in conjunction with the patient. If they had ongoing issues and symptoms, then they continued to see the Care Plus team. If they were doing very well, then it was suggested that they continue with their usual care providers and come back if need be in the future. Next slide, thanks. And so we have sort of come to so the barriers of how this addresses that. The when, we had these agreed points in the illness, and everyone who reached that point wasn't personal. This is just what we did. We positioned it and explicitly in the language as an extra layer of care, high quality care, and involved the team in some sort of introduction points around this. We explicitly included the family in consultations. It was outpatient delivery, so it was a bit more resource friendly and feasible than, for example, community palliative care or inpatient palliative care. It was also culturally appropriate, and it built relationships within the system of care. Thanks. Next slide. So we've come to sort of we've finished the sort of the delivery of this. We haven't got yet the health service outcome data available. That's still to come, but I wanted to present some of the qualitative data that we've done around interviews with patients or people with cancer, their families and clinicians. We undertook this at a series of different hospitals. Overall, we had 203 people with cancer, including 42 with pancreatic cancer. Next slide, thanks. And some of the qualitative data from the clinicians revealed some of the emerging themes, and it seemed that this Care Plus pathway enabled permission to refer, it streamlined things, it assisted the early introduction and reduced the stigma around palliative care. It stimulated collegial discussions and built networks and also trust between teams. So up the top, Care Path normalised the medical pathway. And down the bottom, none of those having to break through the barrier of, referring to palliative care. It's just an automatic thing. So it happens all the time anyway. Before Care Plus, it was difficult. I felt I needed some problem to put in the referral, whereas Care Plus allows us to be more fluid, and it's good to have the concurrent pathway where it can link people from an early point so that as things progress, it makes it much easier. New slide, please. I should say that the language that we used and introduced Care Plus talked about Care Plus, talked about the activities, and then talked about the people who are experts at these sorts of things are the palliative care team. So there was no deception that this was palliative care, but it just wasn't the first word that was mentioned. Next slide, thanks. From the patients and their families, there was this notion of that Care Plus enabled some adjustment of perceptions. There was attention to symptom relief. People talked about time and opportunity to explore concerns and to plan for the future. I didn't know what palliative care was. I thought it was just caring for those who are dying. But this is much bigger than that. It's caring for those on the journey. Like she said this morning, how are you? And I said, I'm in so much pain. Sit down, let me see what I can do to help you. That means a lot to a patient, I think. Care Plus helped me understand that it doesn't have to be the end, being more prepared for the future, thinking about the future. I was impressed that the palliative care physician listened and took all the aspects of concern seriously. So I think that aspect of it, forward planning, and then without all that support, I think I would have been in a worse place. Next slide, please. So what else have we learned? I think it has been interesting that I think that this sort of approach has been embraced by the clinicians. It feels like for a number of clinical groups, there was this sort of difficulty in bringing in palliative care that they were keen to do, but it was very hard, and this has made it easier. We have spotlighted a few processes and been able to sort of fix some of those. The language and training around introduction has been helpful, and to build that into sort of systems of disease education, such as time of education around chemotherapy or what is, for some of the other cancers, multiple myeloma. The early palliative care consultations are different from usual palliative care, and so there are some training implications. And it has built relationships and new awareness of all the things that we all do, and I think that's been perhaps one of the very useful things about this, along with the opportunities for patients and families. So thank you. I'll stop there. I think this has been an interesting project and has really highlighted some new opportunities for palliative care going forward, that if we are to integrate palliative care in an early manner, then we really need to look at these different ways rather than just doing more of what we're doing.